All right. Hello, everyone. I hope you are having a very pleasant day so far. Thank you for joining us today for our session entitled Implementing Effective Care Coordination. You will hear from our wonderful speakers in just a few moments here. And maybe as we're getting started, I wanted to just take a few minutes to do a couple quick reminders. So today's presentation is the 8th in a series of 10 training modules under Take Heart. So this is also the 2nd in a series of 3 around care coordination. As you know, by this point, all of our Take Heart training modules are guided by the roadmap that's been established by the Million Hearts Cardiac Rehabilitation Change Package. And that package is still located on the Resource Center, under the Resource Center within the Take Heart website. The Take Heart website is continuing to be updated, so it is intended to be that one-stop shop for all educational materials, including past training materials, and then we also update it with more recent publications. The format for our training sessions today, we will start with the subject matter presentation that we've got today, really intended to foster some of the chat and discussion through the polling features that should allow you to dialogue maybe with other participants, do some peer-to-peer sharing. Following the session, as we have in the past, we'll provide those implementation guides. We'll provide you an implementation guide that gives you that additional material that supplements today's training session. And then please do make a concerted effort to attend one of the peer action groups that will be held later this month. That's where we're able to provide some technical assistance, maybe help you through some of the more challenging places, but then also for that opportunity for you to hear from some of your fellow colleagues as well. Participants in the live presentation do have the opportunity to receive CEU credits. So the information will be sent following today's presentation. So if you're interested in that, be on the lookout for the email. And then, just one quick reminder as well, during today's learning event, we really do enjoy hearing from you. And probably the way we do that most is through the chat function. So at the bottom of your screen, you will see one of those conversation bubbles, similar to the one that's pictured on the next slide here. And make sure that when you do the chat that you are setting the to field to everyone. Just make sure that everybody can see questions and can be part of that discussion. So with that, I will pass you over to Steve Hines, who can talk a little bit more about the polling function and the rest of our session today. Thank you.
All right, Cynthia, thanks very much, and good afternoon to everyone. We do want to start off with a polling question today. It's always useful for us to understand where you are with respect to care coordination or the topics that were being discussed. And so I'd encourage you to respond to the polling question that you see on your screen now. How would you describe the current status of your efforts to improve care coordination for your cardiac rehabilitation patients? So you see the answers there, and just go ahead and pick the one that you think best describes where you're at in your facility, whether you're doing everything already or you've got some gaps you've started to address, or you know that you've got some pretty big issues, or you're really just not sure what your biggest needs for improvement are. So go ahead and pick one of those options, and we'll give it just a couple more seconds, and then Kayla, I think we can go ahead and close the poll, and then we'll see in just a few seconds. It seems like lots of people have identified that they've got gaps that they've started to address, with less people thinking that they're already doing everything, or they're not sure what their biggest needs are. And so that's great. And we're pretty confident that we'll be able to address some of the gaps that will be discussed on today's call. So thanks very much for your input on that polling question. Just to contextualize where we are today, this is the second of 3 modules related to care coordination. Module 6, we talked about preliminary care coordination activities, whereas Module 8 today, we're talking about how to implement changes in your care coordination process. And then in Module 9, we'll talk about the really important issue of activating your patients to really fully engage them in their own care coordination and in their own cardiac rehabilitation, since those are both really important. As far as our aims for today's session, we want you to understand how to redesign your care coordination to better meet patient needs, and we want you to develop training and policy materials that will help to facilitate your care coordination enhancements. A lot of facilities that we talk with say that yes, we have pretty good processes that are working pretty well, but we don't have them written down anywhere. And if a key person or two left, we would really be in trouble. And so we want to discuss that second issue. And then finally, we want to talk about monitoring and using data so that you can assess how well your coordination is actually going at present and see whether your efforts to improve it are showing results. Our panelists for today's event, Diane Glima, is from the Vermont Center on Behavior and Health and is an associate professor in the departments of psychiatry and psychology at the University of Vermont, where I suspect more of us wish we were than we would have in January of this year. And then Dr. Hisham Scali, the principal investigator for the Take Heart initiative from the director of cardiac rehabilitation in Brigham and Women's Hospital, and has been a really useful and provided some great insights in terms of care coordination on all of our events. And then Patsy Glasscock is our responder to today's events, and we're delighted that she's joined us. We had a great conversation as we were planning for this event. And before we dive into the hearing from Diane and Hisham, I'd like Patsy for you to just give the audience just a brief overview of who you are, who your program is, and where you were at as you entered this discussion of care coordination not very many months ago. All right, we're struggling a bit with the muting and unmuting, so maybe we will work on that, and then we'll pick up Patsy's comments after we've had a chance to talk with Diane and Hisham. So having said that, we'll get back to Patsy in a bit, but let's just turn it over now to Hisham, and he can get us started with today's discussion of care coordination.
Thanks, Steve. Really excited to be here today with my colleague Diane Galima on this eighth topic, or this eighth module actually. And so since it has been a couple of months since we've talked about this, let's start with a review of a few concepts that were introduced during module 6. So really, as Steve mentioned, care coordination is not about one person, and it's really a multifaceted prospect. And so there are, in this slide, we describe about 7 elements of care coordination in cardiac rehab. And really, these are probably familiar to you, and they rely on patient education, where we really have to communicate and reinforce the value and benefits of cardiac rehab to the patients. We have to get them engaged so that they feel empowered and motivated to take an active role in their recovery and in their care. And then the role of care coordination with everybody who's involved with that is really to assess the patient needs and concerns, try to connect them to available community resources, and then help the patients navigate the enrollment process and the care transitions, ensuring and making sure that there are and to verify that there is insurance coverage, that scheduling works for the patients. And really, the other two aspects of this, 2 elements of this listed here, is collaboration. And you can't emphasize that enough, that there will need to be significant collaboration and cooperation between the cardiac rehab program, the referring facilities, and so both internal and external cooperation and collaboration. And then that relies on really developing relationships, several relationships with the providers from within the system and outside the system, to continue to promote the referral of eligible patients, and with post-acute care facilities, so that we can facilitate the transitions of care for several patients, for all these patients. So if we work on all these elements, we can essentially, this will contribute to reducing the time from patient referral to enrollment, and hopefully get greater participation in cardiac rehab. So what does effective care coordination mean for cardiac rehab? Really, it's in these 4 lines on this slide. And just to ground everyone in the same definition, this is an improvement project designed to continue improving referrals, but it also calls to address inefficiencies and inequalities within the program that might be hindering referred patients from getting enrolled. So really, it's not only referral, but also the enrollment and then the completion of the program. So we suggest that an effective care coordination system consists of a group of workflow processes and activities designed and systematically executed to help ensure eligible patients get referred, enrolled, and participate fully in cardiac rehab. So this project will ask from you to be the change that will get involved at securing the referrals, getting patients in, and helping them complete rehab by enhancing and establishing care coordination for all patients, and especially those that are less likely and that might, unfortunately, be less likely to enroll and be referred. So we have to go get those patients that often suffer from the health inequality referral that we talk about in many aspects. So it is also important to realize that care coordination takes place not just during the referral phase, but throughout the entire spectrum of care, the continuum of care for the patients, from the incident events, whether that be a clinical event such as a heart attack, myocardial infarction. It could be a procedure in the hospital such as bypass surgery or revascularization or valve procedure, or it could be after that at an outpatient ambulatory visit where that happens. So care coordination involves this entire spectrum from the incident event all the way through referral, participation, enrollment, and participation in cardiac rehab. And in some programs that do phase 3 programs, care coordination can continue there to help ensure success. So we are going to hear some thoughts from a patient on the next slides, and then we'll continue with my colleague, Dr. Diane Galima, right after that.
Today joining us is Patricia McNair, a former cardiac rehabilitation patient who's going to share her perspectives and insights. So Patricia, let's start by telling us a little bit about what took you to cardiac rehab. Were you hospitalized? Did someone discuss cardiac rehabilitation? And what were your initial thoughts?
Teresa, my initial event happened. I had a mild heart attack. So that sent me to the hospital, emergency room. After I got out, of course, I had my appointment with my cardiologist, and she discussed cardiac rehab to me, the program with me, rather. And my first thoughts were, it's an exercise program. I could achieve that goal at my local health club, that I belong to. So those were my initial thoughts.
What factors contributed to your decision to enroll in cardiac rehab?
Well, when I went back to my cardiologist, she did a very good job going into details about the program. And one of the things I found out, wasn't just exercise. It also, we had a relaxation class, she said. So there's a relaxation yoga class, and a nurse specialized in nutrition, explaining not only what we should eat and how many calories, but how do we shop at the grocery store, stand around the perimeters, So she told me about that. And then she also told me about the nurse on staff. When I come, they would personalize the program for me, which I thought was great because it wasn't a cookie cutter thing. They would create a program plan that fits my need. And also I would attend medical classes, meaning not, medical classes on how to a heart works, right? How the heart functions and the medications that we take and how those medications work in our bodies. So those things said to me, okay, this is more than going to work out. And so those were the factors that contributed to my decision to enroll.
Great. And so from your perspective, what types of support do patients need to enroll and participate in cardiac rehab?
The first thing that comes to mind is the insurance company's willingness to pay for the program. The second thing that comes to mind is, of course, they need the support of their families and they need the support of the CR staff, of course, understanding. But they also need support from their employers, having the availability in their schedules to allow people to go, But there's one other thing I think is cardiac rehab program should have times that are more than once or twice a day, to offer maybe 4 or 5 times to give the patient a better opportunity to go.
Okay. And so finally, what do you think CR programs need to know in order to better support patients?
Well, of course, they need to know their personal life a little better, right? So they can understand the person. Some patient comes to the center, a patient comes to the center, may have diabetes, right? So when that person exercises, might need to check their blood levels. So that's one thing. Well, I can just say from my nurse, she made me feel more not as a patient, but someone she really cared about. And to me, that was important because I felt like I wasn't just showing up, that someone cared about me. And then, of course, they can have, I think I said before, more opportunities for people to go. But the biggest thing for me is to see me as me and not as a group of people. So.
Great. Well, thank you so much for sharing with us today.
You're welcome. I appreciate being here and thank you for asking me.
All right. Well, that was a wonderful video. I mean, thank you, Ms. McNair, for providing that interview because it really tees up a lot of the discussion that we have moving forward about talking about addressing patient needs and concerns. So I can take a minute here and we can start going through some of the common needs and concerns that you might see in your patients. So one thing to keep in mind is, and I'm sure you've noticed this throughout the Take Heart curriculum, is that there's this big emphasis on the importance of working as a team. So we think of cardiac rehab itself as, multifaceted, and so it shouldn't be a big surprise to anyone that also getting the patient involved and doing this coordination is also a multifaceted approach as well. So illustrated here are some of the elements of a team that may be involved in these processes that you would want to get involved. So this can start from, for example, data analysts, so people who can look at who's not coming and how you're doing when you start changing things, involving the clinicians and the intake staff on the CR side. And then one really important element is trying to identify folks that might serve as your cardiac rehab champion. So one suggestion on this front is to try and identify these people that can really be the champions for the program. And it may be that you might have one of these on the inpatient side and the one on the outpatient side as well. And also a person that you can involve in the team is this idea of a patient navigator, someone that can reach out and really help the patients navigate the system. And these roles don't necessarily need to be served by a specific person. I mean, these may be nurses, but they may be other types of folks as well, including previous patients. But the idea here is that this may take a team to really get coordination to happen successfully. And I think the most important part for all these elements of the teams is that you have people that are giving consistent messaging to the patients about the importance of CR and that are interested in listening to the patients and learning about the barriers and really trying to overcome them in the effort to help people get into CR and stay there. All right, so I want to start a little bit by talking about kind of the environment that these patients come from. So this is one bit that I really love from that video is that I'm I'm a person, not a group of people. This is really important. You know, people do not exist in a vacuum. This is not a patient existing in a vacuum. They're a product of their environment. And by thinking about the social determinants of health, we can be sensitive to some of the different types of the environment that that person is existing in. And so this can be a lot of different parts of their environment. So we think about not only their environment that they grew up in and the kind of resources that they had as they developed, but also their current access to resources. So what access do they have to healthcare? What access do they have to financial resources? But also their social environment. What is going on in their community or their family that's important. And also even just their built environment. What, you know, do they have access to sidewalks? Can they take the bus to get to CR? What kind of environment is this patient existing in that's going to determine what their barriers are and also the facilitators are to getting into cardiac rehab? So one important thing to think about when you're trying to improve access to CR, improve care coordination, is really thinking about first about who are the patients that are missing from your program currently. So you may have a good idea of the patients that are getting to your program because they're the ones that don't need a lot of help. They show up, everything goes pretty smoothly. You're probably familiar with these people. They might have white collar jobs or be recently retired. So they have opportunities and they have like paid leave or the ability to come in. They have resources like a car, things like that. So these are the people that you are probably seeing most of the time anyways. They get a strong referral in the hospital to come to cardiac rehab and they can make it happen with the resources that they have. So what you might need to start with is trying to figure out what are the people that you're not seeing. So if we look at the research and the general characteristics of populations that you don't see in CR, one of the things is that you see that the people are relatively young or relatively old are the ones that don't end up in cardiac rehab. So on the younger end, you might have people that are still working or caring for young children, and those things kind of interfere. And then the very old, you might get social isolation or frailty or other barriers. And then other things are predictors of not attending, such as being female or being from other underrepresented populations, people with lower educational attainment, and then of course people with inadequate insurance. These are the ones that are less likely to participate in cardiac rehab. All right, so how do we get them into cardiac rehab? So one of the suggestions here is to kind of redesign the care processes to really make this patient-centered, to put the patient at the center of the process. So one of the important things, so once again, like we heard from the patient testimonial, including the patient and the family in the discussions could be important. So and this is important when we're thinking about different cultural backgrounds as well. For example, there are cultures where decisions around medical care are not up to the individual. It is a family decision. So just being sensitive to the person in the context of their larger social environment can help kind of drive who should be involved in those initial discussions. And this can also lead to how you tailor those interactions and what you focus on when you're talking about that. So once again, thinking about the patient in terms of their environment and their social environment especially. So what is their role in their family right now? What is the impact of this event? What is their role at playing at home, and what do they need to be doing there, and what are their concerns? And so that can give you an idea of where they're coming from. And then when you're hearing from them about what their current situation is, then you can get a better feel for how you educate the patient and the family, preferably in plain language, about where the patient is currently and what their goals are and how cardiac rehab is going to help them get to those goals. And I think this is just important to remember that the goals for everyone after they've had these kind of events aren't always the same. Some people may be really concerned about returning to work. Some people may be worried about being able to play with their grandchildren. And so it really takes kind of a patient-centered approach to understand what is the motivating factor for that particular patient. So, and just to touch on that last bit, it's really important to listen to the family and the feedback. So this is much less about talking at the person and then instead having an active conversation about those considerations. All right, so to talk about some of the common barriers we see in cardiac rehab, there is a lot of things that can get in the way of people going to cardiac rehab. And I think my main point is going to be is that every patient is different, and the barriers that they have to overcome are going to be very specific to them. So once again, it's the importance of, just realizing that these barriers are out there and then finding out what's the specific barrier for that particular person. And sometimes it's just kind of amazing what the barriers are to some particular people. I'll just give one example. I won't ever forget this one lady I was talking to up in the hospital and trying to convince her of the value of going to cardiac rehab. And she looks at me and she says, "I'm caring for my elder mother. My son just got arrested. My car got repossessed, and they're foreclosing on my house right now. I don't even know where to start as far as being able to do anything else in my life, but just trying to stay on top of all of that." And I'm not going to say everyone's barriers are going to be that immense, but there's a lot to consider when thinking about. I think one of the things that you have to understand is there are probably very few patients that don't want to improve and be able to recover and get back to their lives. And it's not that they don't necessarily care about their health or working towards it, but often there are other things going on that seem very important and overwhelming. And so for folks like that, where a lot of the other stuff just seems so overwhelming, it may be more of a conversation about, you have to take care of yourself so that you can take care of other people. And how can we possibly tailor what we can do for you so that you can still do it and still recover and still take care of what you need to do. So just to kind of go over some of these barriers. So these are all things that you could possibly see. People do vary in their cultural values and beliefs, as I touched on. Need to work. There's going to be people that have some white collar job that gives them sick leave. And there's going to be a lot of people that are working hourly that not only, aren't going to get paid sick leave, but they're also losing their income to come to get medical care. And there's going to be people that are not only caring for their children, or they're caring for their, for elder adults in their family. And financial is a big one as well. It's a big push to try and eliminate copays for cardiac rehab because we know any sort of cost share is going to be a barrier. And then, educational barriers as well. So this can just take a lot of different, can manifest in a lot of different ways, with either people not realizing what the benefits of cardiac rehab are or what it is. And as we heard from that testimonial, it's not always clear what the benefits are for a particular person. And then we have to worry about behavioral health issues as well. So anxiety and depression, very common in this population. Social isolation, especially, for example, the older women. And then just as I mentioned, transportation. If you don't have a way to get there and you can't afford it, then that might be an issue. And sometimes these things aren't terribly obvious as well. So you might have an older lady, for example, that has access to a car and so wouldn't necessarily be eligible for some services. But if she's too afraid to drive herself, for example, in the rain or something, that's still going to be a huge barrier to her. And those are things that you may not know about unless you take some time to really suss out what's going on with a particular person. All right, so those are talking about the barriers. So some of the possible solutions, when we're talking about some of these individual concerns, as was mentioned in the video, really trying to leverage the other people in that person's lives. You're not always going to have family or that you can kind of drag in and help support the message, but if they're there, you should leverage it. And obviously connecting with the other community resources and services that are available in the community. I mean, there are often resources out there, whether it's for meals or transportation or behavioral health, and just being able to know what those are and be able to connect the patients with them is very useful. A lot of what I get out of this as well is sometimes just having the ability to adjust how the program is delivered could overcome a lot of these barriers. So if you go up there and talk to someone and say, this is 36 sessions of cardiac rehab, you've got to go outpatient, this time of day, that's going to be overwhelming and seems very, like, no, there's no way I can commit to that kind of stuff. Whereas if you had some flexibility, you can say, at least come in for a consult so we can get you checked out and see how you're doing and give you some ideas of what you might be doing at home. That's at least something, and that gets them started. And that may seem much less overwhelming than kind of committing to the whole 36 sessions. And so similarly, when we're talking about other barriers, so if people are working or they have childcare, they might benefit from having other options such as flexible hours, night hours, weekends, that kind of thing. Or these more hybrid versions of CR where you require some in-person because obviously you want to be able to get a feel for the patient and their risk factors and what their capacities are, but also being able to support them doing more on their own time at at home outside of the usual working hours. All right. So thinking about some possible solutions to financial concerns. So it's always kind of a shock to people if they are starting CR and suddenly they've been told that they have a $70 copay. Sad, but it happens. So it's important to really kind of confirm that insurance coverage and being explicit about the cost from the start. I do hope that the efforts to eliminate copays continues to move on, but until then, that's a reality we have to deal with. So thinking about other ways of kind of balancing out the cost, can you set up payment plans for the patients? Can you provide support to allow them to apply for other insurance options or for other subsidies? One thing that we do at our program is that we have a philanthropic fund where some of our more affluent graduates will donate money to help defray costs for people that have insurance that is not allowing them to participate. And another thing you can think about when you think of the finances of getting to CR. So there's going to be a subset of the population for which just the cost of transportation or getting to CR is a big barrier. So I know that for some programs, one of the kind of creative ways they've dealt with this is kind of used transportation support as an incentive to get people to come to their sessions. So if you come to the session, then hey, we've got these gas cards. We can give you a gas card so you can come to the next session. But just these ways to kind of help motivate folks to come and also help them overcome the barriers to getting there. All right, so looking at educational barriers. So one thing that's important is that the educational materials that are provided by programs is best if they are materials that are approachable by people from a wide variety of backgrounds. So plain language, diverse populations represented, those are the things that you want to see on your educational materials. And once again, talking about just trying to encourage the patient as far as wanting to go to CR given the benefits. So this is another thing that you can talk to the family and help leverage them as far as reinforcing that value of CR. Does the patient think that CR is not necessary or not for them? Can we help talk to the family and be like, this is why we think it would be good for them? And so another thing along those lines is if you can find people that can serve as your ambassadors that have that experience, you can see the value and people that have lived through the experience and sharing that information with others. Like, you may not think that this is right for you, but I did this and I'm like you, and so this is why I think it would be good for you too. Being able to have that experience rather than someone just telling them that they should do something. And so that's, you can also make sure that the staff are trained in this active listening, patient-centered approach of really just trying to meet people there. I mean, motivational interviewing is obviously a technique of success for that. And really just trying to make sure that the benefits, like I said, the goals for the patients are going to be varied. And so if you can figure out what the goals of the patients are and express in plain language why cardiac rehab is going to help them get to that goal, you're going to help motivate them into CR. All right, and I of course can't talk about barriers without talking about behavioral health. And so I think one of the things that's important for programs to remember is you can probably go a long way just by destigmatizing the presence of psychosocial issues in cardiac rehab. So there's a lot to be said just for explaining to patients that we know that it's common for people to have depression and anxiety. You went through a lot. This is going to be causing you stress. You may be sad and not even know why. These are things that are common and it's okay, and we can help you work through it. I think there's still a lot of stigma about even talking about it, and that's a good kind of first step. But yeah, screening for anxiety, depression, social isolation, figuring out what these barriers are, and then connecting to existing resources in your area. I mean, maybe you have behavioral people connected to your program. Maybe you have them connected to your hospital, but just knowing where they are and how to connect with them is important. And this is another spot where those patient ambassadors can be helpful too, is reaching out, and especially with the social isolation piece. The hope is that you can bring someone who is socially isolated into CR, and then CR will provide that added benefit of kind of forming a social connection for that person as well. But once again, just really knowing what your community resources are and how to connect them to your patients is key for supporting that area. All right. So as I mentioned, transportation can be a real issue I mean, we know that people without transportation are not coming to CR. This is a big issue in rural populations especially. But there are various ways that you can try and support this. Are there bus passes that can be provided? Can you find families or caregivers can provide transportation? Are some programs set up carpools between their patients? And then this is another thing where when we talk about alternative delivery of programs, that could be useful as well. Maybe the patient can only get to CR once a week, but what can you be doing the rest of the week to help support them? And just really trying to reduce the costs of transportation and getting to your program as much as possible. I mean, the last thing you want to do is have someone who wants to come to CR, but because of the parking costs, that's kind of the last straw for them to be able to get to you.
Yeah, thanks, Diane. That was really very interesting. And, just to share a real life story, I'm sure you've had these experiences many times. We had this woman who wasn't sure whether her husband could actually bring her to every cardiac rehab session, and our intake coordinator called her husband directly and invited him to the first session. And once he came, he committed to actually driving her all to every session. So it's really that taking that extra step of trying to involve the family. It could be the kids, could be the parents, it could be the neighbor, and so it would be nice to continue to do those things. As you said, there are a lot of barriers, and so figuring out where they are, which patient has what barriers, and how we can overcome that, I think is very important. So I think with so far what we've heard really is that care coordination is a multifaceted program. Aspect. It's also multidisciplinary, touches on a lot of subjects, and so with that, it would involve redesigning the way we do work and by who does it and when it's being done. So what you would want to do, and the next few slides are going to be a little general, but I think they're really important in getting the concept here that first you want to start with easy fixes and progress to harder ones as you go. So, and you want to probably map out what are the things that you're going to change and when you're going to change and who's going to be involved with that. And there is a lot of not trial and error, but there is just a lot of iterations in figuring out, okay, what works, what doesn't work, and then making small changes until you get where you want to be. It's important because it's it's a team and everybody's involved. It's important actually to involve people in your staff and your team in most of the decisions and how things are done, and being receptive to comments and suggestions and being able to alter how we do things. So with that, you would create a flow chart and try to follow it and see which parts of the flow chart don't work and how you can replace them at the next iteration. As I mentioned, it's important to educate the staff about the new workflow and then continue, reward people who are consistent with the flow chart as it's being implemented until it gets changed. So next slide, please. The workflow processes that are important to support referrals are really the first step. And so one of the things to do is really develop and document and communicate a standard way so that your automatic referral works successfully. Automatic referral, what it does is that it standardizes the referral process. It makes it that we go beyond those biases that make us refer some patients and not others. We want to refer every eligible patient, and then we can work on the next hurdle. But the first step is making sure that every eligible patient is getting referred, and then so for that we need to screen all the patients that are eligible and how they will be referred and which program they will be referred. This slide lists all the steps that will be needed for that and who are the different people who will be involved in that discussion and process. So first thing is we would want to develop a standard referral policy for all eligible patients. Not only patients who are in the cardiology units, but also patients who are in non-cardiology units. So patients who are admitted to a medicine unit, or into an orthopedic unit, for example, because there is overflow, the hospital is full, and your patients with heart failure or with an MI was admitted to another floor, you want to make sure that you're capturing those patients, not just the patients who are on the cardiology floors. And you would also want to do, what you want to make sure is that patients who are in your hospital, but they don't live in your community, they live quite a distance away, you want to make sure that they get to a cardiac rehab program. They may not get to yours, but you want to make sure that they get to a cardiac rehab program that's convenient for them, where they're going to be able to enroll and participate and complete their program there. So the other thing you want to do here is also have a process where you have a conversation from clinician to another clinician, so that your transition of care is smooth. And then, because a lot of these patients are often complex, have comorbidities and so on, so you want to make sure that there is a way to track the complexities of the patients, and that the transition is smooth there. So this transition between phase 1 and phase 2 is very important, because that's what actually, if it is done well, it can shorten the time between the index event and enrollment and participation in cardiac rehab. And we know that there have been studies showing that actually the shorter that time is, the greater the likelihood that patients will actually enroll in cardiac rehab, and eventually might even participate in more sessions and more likely to graduate from cardiac rehab program. So for these things to happen, to make that transition smoother, you want to make sure that to confirm the discharge referral. So you want to make sure that there is a referral that has been done at discharge. You want to make sure that the discharge diagnosis and the referral diagnosis are actually accurate, and so will help you enroll that patient. You want to track medically complex patients who may not go home directly, but might transition by a short-term rehab or a SNF facility before they can come to your cardiac rehab. So you want to have a process in place that would allow you to make sure that these people don't fall through the cracks once they go to a short-term rehab. Nobody hears about them anymore, and then they're not referred and they don't participate in cardiac rehab. So you want to have a process that you can capture those patients afterward. You want to, as mentioned earlier, you want to have relationships between not only your own cardiac rehab program and the referral units where they're coming from, whether they're on a cardiology floor or not, but also you want to have a relationship with other cardiac rehab programs that you might help transition your patients if it's more convenient for them to go elsewhere. Insurance verification is important, because as Diane mentioned, you want to make sure that this is a service that's covered, and how are you going to help the patient? If someone, if they get a $70 copay, not everyone can afford that, and for those who are not insured, or for those in whom you don't check their insurance, they may get hit with even a higher bill. And once they get that first bill, they're going to stop coming. Whereas if you take that ahead of time, you're proactive about that, you may increase the likelihood of them coming back to you. And so the other thing is really connecting and figuring out what are the community resources that are available, and that will help you with that phase 1 to phase 2 transition. Once you go to phase 2, there are, again, other processes there that you want to work on. And again, the concept there is really developing a workflow and the process that's going to help you throughout this entire continuum of care. So you want to screen the patients for their needs and concerns, as Dr. Galima very nicely demonstrated there throughout. There are several barriers and several hurdles the patient can encounter. So you want to see which would apply to every patient, because and not everybody is the same. There's no one size fits all. So you want to make sure you individualize the needs and respond to those appropriately for every patient. And then you want to connect these patients with available resources. In terms of process, acknowledging the referral promptly is extremely important. It allows you to close the loop with the referral program. And if you are just in the path, you're making sure that the patients within your hospital is going to another rehab program, you want to make sure you confirm that the other rehab program has received that order, and they will take it from there. That's a warm handoff that you can actually help facilitate. within that process, you want to make sure you have a workflow where not only you have the acknowledging the referral, but you have scheduled the first intake, the evaluation, the orientation for the patients, and whoever else is going to be involved in that in the care of that patient. And you want to help support these patients throughout their entire cardiac rehab participation from the first session until they graduate. So this entire process of care coordination, as we mentioned, involves several people throughout the entire spectrum and continuum of care, and it might not be very different from what you're already doing, or it may not be very different. You might already be doing some of these things, but the key part here is really documenting and trying to have this as a process where you have everybody on the team involved in this process. You have it documented as a workflow and as several processes addressing all the hurdles here, so that you maximize the efficiency and the participation of your patients in graduation. So that means that you might need to hire people, you might need to change the job descriptions and expectations for some of your staff. And the best way to do this and to retain staff and retain a happy staff is to seek input from them and involve them in the entire decision process and the redesign of their jobs. You want to clarify the ownership of their roles and what they're going to be doing. And unfortunately, it is not uncommon for staff to turn over, for staff to move on to different places and different roles. So you want to make sure that everything is documented, and so that when that staff leaves the institution, that knowledge and experience that they have doesn't leave with them. And you want to make sure you have the processes and the workflow charts there, so that whoever is part of the team and whoever you're going to hire next can continue to work with that same efficiency that you have. So you want to make expectations and performance criteria clear for everyone. The orientation guidelines for your entire staff have to be written and clear for everyone. And then, as this is a team, and throughout the entire workforce, it's important to provide appropriate mentorship, and where young and junior staff have people to look up to, and they can continue to emulate, and they can continue to receive transfer knowledge from them as well. So the key there is really to empower your staff with the knowledge they need to be successful. So you want to make sure the entire CR team, from the phase 1 all the way through phase 2, has a thorough understanding of how the automatic referral system works, how to access the information and reports needed for their position, to know where things that work and things that don't work, and how to improve them, and provide supplemental training throughout the year for, as Diane mentioned, conversation techniques, how to change that based on the patients and based on their needs, and also be very sensitive to patient needs and to the patient that we are less likely to refer and enroll. As we mentioned, women, very older or younger patients, minorities, lack of education, lower socioeconomic status. You want to be very sensitive to those patient populations, and really work harder to get those patients so they can really benefit from the cardiac rehab. And so maintaining a continuous cultural sensitivity training throughout for the program, and I'm sure it's part of all of the institutions, is extremely important there. So I think we're going to finish on that and pass it back to Diane for the next part.
People were talking about bringing family members to orientation and including them in CR programs, that was a thing that was much more prevalent prior to COVID, and that hopefully we can get those kind of things reinstated fairly soon. And I am all in support of that. That it always seems to be valuable to be able to bring them in. I know our program allowed family members to exercise during the same time, and that was very helpful for some people. So I'm glad to see people thinking in that direction. All right, I'm going to move on here to monitoring using data to support care coordination. So one of the things that we want to make sure that you do is that you're at least keeping an eye on the data and how you're doing. It would be a shame if you make good changes and we're seeing improvements and didn't have some metrics so that you could report back to your systems about how great it is, the work you're doing. So before we go into kind of the more formal measurements, one of the things that's just really important is that you need to, when you're going into these kind of changes and thinking about changes, it's really important to listen to both your staff and your patients about how things are going. They're going to be these invaluable sources of ideas of both how you might improve and how things are going and feedback about how changes are happening. So it needs to be an open conversation without judgment about, what's working and what's not working, because they're the, boots on the ground that's gonna help you figure out what needs to be done. All right, so when we're talking about, as I mentioned, when you're making changes, you want to kind of have performance measures that have good definitions along with them so that you can look at the data as these changes are happening and see if you're being successful and adjust as necessary, and of course give you reasons for celebrating the successes that you do have. And so what does success look like? So this is just a list of different metrics that you could potentially use, but do not let perfect be the enemy of the good. Any of these is a good thing. So you can pick a metric that you think would be easiest or most valuable to focus on and just start with that. There's no reason to have to look at everything, but the important thing is really just to be looking at something. So like I said, you have that. And because the goal is that you're bringing in patients that are coming and, providing value. They should be coming in. They're supposed to be referred. They'll provide benefit to your program. So this should be a valuable service that you're providing, getting these patients in.
All right, thank you very much to our presenters today, and I want to bring back Patsy and just Patsy, share with us your perspective on the things that you heard from today that really resonated with you as you were going through this process, and the changes that you made directly in response to some of the suggestions that you just heard discussed again today.
Okay, can you hear me now?
Very good, yes.
Good, okay. This was a really good session for me. I've always thought care coordination was a really important part of the care we provide for our patients. We're a small community hospital, rural hospital, and we serve an 8-county radius. So we have a lot of the barriers that you talk about in this session, and it was helpful to hear some other people with their ideas on how to help patients overcome the barriers, and also ways to incorporate a lot of these care coordination duties into the nursing staff that we currently have. We have 4 RNs, but they all work in other areas as well. And so it was helpful just to brainstorm about ways to be able to utilize what we have, because we would not be able to hire someone that would be dedicated to doing care coordination.
Thanks. And as you look back and look forward at this point, of the care coordination things that you know that you really would like to improve in, what are some of the things that are still on your to-do list, the things that you know you want to do better to support your patients that you just haven't been able to do yet? And why have those things been particularly challenging for you?
Well, actually, one of our biggest challenges is the automatic referral is helpful, because in a hospital our size, we do heart catheterizations. We don't do interventions yet. We're planning to start PCI later this year. So most of our patients that come into our hospital get transferred either to Austin or to San Antonio. And so there were some barriers there just to get our patients back to cardiac rehab in our community. And we're still working on that. One hospital that we referred to, we've been able to connect with the case managers there, the phase 1 nurses. They know who we are, they know how to contact us, and they've gotten really good about referring patients back to us when they're discharged from those hospitals. But there's a few hospitals yet that we haven't quite got that relationship with. And so that's one of the things going forward that we really want to continue to work on.
Yeah, thanks very much. And we encourage you, if you're in the audience and you have a question for Patsy, or if you want to share an insight, something that you latched onto from today's panel that you are going to work on, by all means, put those into the chat. In the meantime, Patsy, are there things that you're doing in particular to enhance the care coordination of some of your underserved populations, to get more of them into cardiac rehab? And if so, what are some of those things that you're doing?
It was interesting to really take a look at that to see what the breakdown was with our patients. And so we have spent some time working with the primary care providers, educating them a little bit better about our services, and working with some of the clinics in town to reach out to some of the populations that have not really been represented in cardiac rehab. There are some clinics in town that deal with folks who are underinsured, and our hospital has a relationship with those clinics to be able to provide some services to patients that are underinsured or not insured at all, and just to be able to educate the staff at those clinics that even so, they can still refer their patients to cardiac rehab, because we do have resources to be able to help them. And I think building that relationship has been helpful to us so far, and we'll continue to work on that.
Yeah, and it's terrific that some programs like yours are actually using resources from some of your patients to support some less advantaged patients, and that's just a reflection of a real commitment to community that is admirable wherever it exists. And if that's not something that some of those of you in the audience have tried up to this point, it may be something that you want to consider, because we do hear consistently from patients that cardiac rehab really has benefited them, and is something that they really want others in their situations to also be able to benefit from. So thank you very much, Patsy, for your insights, and to our panelists today. Just looking ahead to our action steps in the future, continue working with your team on defining and assigning roles and responsibilities, and working on the training associated with care coordination. We know there's been a lot of turnover in a lot of programs, and there will probably continue to be turnover due to staffing shortages in healthcare. So getting those processes for orienting new people and training people, getting them improved and really prepared to cope with change, I think is one of the things that you can proactively do to sustain the quality of the care that you provide. Then, in addition to that, we really want you to explore the steps and the actions and the resources that are available in the Module 8 implementation guide that's posted on the Take Heart website and is accessible to you at any time, day or night, 365 days a year. So you can always go there if you're struggling to sleep and find some really good insights to the implementation guide. And then we want to encourage you to participate in one of the upcoming peer action groups next week. Those really provide you an opportunity to ask additional questions after you've had a chance to process the information that you've heard today. So we really encourage you to go to those. Looking at the dates for those peer action groups next week, those will be on the 14th, 15th, and 16th. And if you haven't registered for one of those, by all means do that and attend, since that will really help you with your care coordination activities. Now, Module 9, as we near the end, we just have 2 more modules to go. The focus of Module 9 is on activating patients to engage in complete cardiac rehab, and that will be on July 13th from 2 to 3 Eastern Time. And there's a registration link that you can get that you can use perhaps now or else once you receive the slides, which you will in a day or two. And that will really help you extend beyond the information that you heard about today. Today, the focus was more on things that you can do. Next module, the focus is more on things that you can help your patients and their families do to fully engage them in care coordination. So thank you very much for your attendance today, and we hope it's been helpful to you. And we welcome your responses to the survey questions as you close out from this afternoon. So thank you again all very much, and we hope that you have an excellent rest of your day and an excellent rest of your week.